All right, let's jump right in. In traumatology, if you can't describe a fracture properly, you can't fix it properly. It's really that simple. So today, we're going to break down the essential language you need to know for describing fractures and how the pieces get displaced.
So here's our game plan. We'll start with a solid framework for talking about the break itself, then we'll get into the specifics of classifying how the bone fragments have moved, and we're going to wrap up with a critical clinical note that you absolutely have to remember, especially when you're treating kids.
Okay, first things first. Why do we even need a universal language for this stuff? Well, it's pretty simple. In surgery, you just can't afford any confusion. Ambiguity is your enemy.
I mean, think about it. This isn't just about passing your exams. A precise, universally understood description is what allows a surgeon in one city to look at a report from a radiologist in another and know exactly what they're walking into. It is the absolute foundation for good treatment.
All right, so let's start building that framework. Step 1 is all about describing the intrinsic characteristics of the fracture. Like, what does the break actually look like on the inside? First up, we look at the orientation of the fracture line. This immediately gives you so many clues about how the injury happened. A transverse fracture, that suggests a direct bending force. A spiral fracture literally screams that there was a twisting or torsional force. And an avulsion fracture, well, that tells you a ligament or tendon pulled so hard it ripped a piece of bone right off.
Okay, next question you ask is this a complete break? Did it go all the way through the bone, from one cortex to the other, or is it incomplete, like those green stick or torus fractures you see so often in kids, where the bone kind of bends and cracks but doesn't fully snap in two?
And this one is huge. You have to ask, what was the condition of the bone before it broke? Was this a traumatic fracture in a perfectly healthy bone from a major force? Maybe a stress fracture from overuse? Or, and this is so important to catch, is it a pathological fracture where a seemingly minor injury causes a break because the bone was already weakened by something else, like a tumor or severe osteoporosis?
And finally, for this first part, we count the pieces. This has a huge impact on your surgical plan. A simple two-fragment break, that's one kind of puzzle. But a comminuted fracture, where the bone has just shattered into multiple pieces, well, that's a whole different ballgame.
Okay, so that's part 1, describing the break itself. Now for part 2, where did all the pieces go? The rule is we always describe the position of the distal fragment in relation to the proximal one. In other words, how have things shifted?
Now, to describe where those fragments ended up, we've got 4 main types of dislocation. And yeah, they've got these classic Latin names, but they're the bedrock of this universal language. So let's break them down, one by one.
First up is ad latus. Just think of it as a sideways shift. The two bone fragments have just slid past each other, maybe medially, laterally, dorsally, or ventrally. The key thing to remember here is that their long axes are still perfectly parallel. Next, we have ad axum. Now this is all about angulation. The fragments aren't parallel anymore. Instead, they're forming an angle right at the fracture site. This is your classic angular deformity, and you'll usually describe it by which way the point, or apex, of that angle is directed.
Okay, number 3 is ad longitudinum. And this one is all about length. Has the bone actually gotten shorter? Or, in some cases, has it been pulled apart? This isn't just about where the pieces are sideways, but how they've affected the bone's total length.
And this breaks down into 2 flavors. You've got cum contractione. That's when powerful muscles spasm and pull the fragments past each other, causing them to overlap and actually shorten the limb. And then you have the opposite, cum distractione, where the pieces are pulled apart, leaving a gap. And last, but definitely not least, we have odd peripherum. This is all about rotation. The distal piece has literally twisted around its own long axis compared to the proximal piece. And as you're about to see, this one can be the most subtle and the most dangerous if you miss it. All right, let's pull all of this together because everything we've just discussed leads to one incredibly important clinical point. This is a real pearl you've got to lock away, especially if you're ever dealing with pediatric trauma. So here it is, the big takeaway. Kids have this almost superpower-like ability to remodel bone. You can have a fracture with some sideways ad latus shift or some ad axum angulation, and over time, that bone will magically straighten itself out. But, and this is a huge but, that rule has one major exception. Rotational deformities do not self-correct, ever. And that right there is why spotting and perfectly fixing any ad peripherum displacement is totally non-negotiable. If you don't get that rotation perfect, the bone will heal in that twisted position. The functional consequences down the line, for their gait, for joint alignment, for future arthritis, can be profound and permanent.
So let's leave you with this thought to chew on. Imagine you miss a subtle rotational error in a kid's femur fracture. What does that look like when they're an adult? You're talking about a lifetime of abnormal gait, uneven wear and tear on their joints, and maybe even early degenerative disease. It's the ultimate proof that getting the description right isn't just some academic exercise, it's everything.